As of now, we have enrolled only AML patients, and that's by chance, not necessarily by just design or restriction. But it just as it is, the first 9 patients that have been enrolled are all AML patients. So I think that obviously continuing to understand the response patterns and the activity within the AML population, but also extending this to other CD33 positive malignancies as well, such as MDS, and even potentially mixed phenotype acute leukemia, in which we know we are very desperate to have effective therapies for that population as well. So I think that we can extend a broader net as we continue to enroll onto the study about other disease subtypes, specifically or primarily myeloid disease subtypes that may provide, where this may provide potential benefit. But in addition to that, I think it's also where do we use it? All right, this is a therapy which is currently being used in a more heavily pretreated population, patients that have failed prior therapy, and in some cases even failed prior allogeneic stem cell transplantation, and yet the disease has still relapsed. And we're seeing activity in these patients. So the natural progression is also to say, well, if we see it in heavily pretreated patients, can patients benefit from this even in earlier lines of therapy? And so could we potentially use this as a consolidative aspect, even for patients in the first remission, potentially, is one potential opportunity. So I think having an effective therapy in a heavily pretreated relapse refractory population, that's wonderful. But I think to optimize it, if we can get this more effective therapy earlier to patients, and can we actually translate not just to remissions, but actually to cures? And I think that's where the possibility potentially exists.